the next part of our agenda, we're going to be hearing from our aging RDT. We have our 3 co-chairs of the aging RDT, led by 2 powerhouse community members and a powerhouse clinician and researcher. So our first community co-chairs is Michael Parsons, who's a Indigenous elder and knowledge keeper, who was very involved in the CTN C4 consultation. So thank you for that, Mike. And he finished his bachelor's in social work in 2020. So congratulations for that, Mike. He coordinates the JIPA Home Fire Research Project and is the nominated principal applicant of the 9 Genders Research Project, which is his passion. And I've personally learned a lot from Mike, as he's always championing teachings about Indigenous cultural inclusion and humility and JIPA. So thanks, Mike. Guy-Henri Godin is our other community co-chair for the Aging RDT. Guy-Henri is a CTN CAC member, and he's been in that role for over 6 years, representing the Canadian Hemophilia Society. Guy-Henri, I feel like I've known you for a decade or 2. I don't know why, but you're always around helping. So thank you. He always has a smile on his face and provides constructive feedback. Guy-Henri has been living with HIV for over 30 years and was one of the first people in Quebec to disclose his HIV status publicly. Guy-Henri is also a lawyer and a member of the Quebec Bar Association, and has practiced law for more than 3 decades. Madeleine Durand is a general internist at the CHUM in Montreal and a clinician researcher there. She's trained as an epidemiologist and is most well known as the nominated principal applicant of the prestigious team grant, the Canadian HIV and Aging Cohort Study, CTN 272. And Madeleine is also well known for always meaningfully involving the community in her work and being open to learning. So I'm going to pass it over to you 3.
Thank you very much, Mona, for the kind introduction. So, and thank you to the CCM core for making place for the HIV and Aging RDT in this meeting. It is very humbling to be here. It is an honor to follow such distinguished speakers. So thank you very much. We're going to briefly introduce for 15 minutes what our HIV and Aging research development team has been up to. So as I was saying, thank you very much for the space in this meeting. And without further ado, I'm going to pass the mic to Guy-Henri, who will present the beginning of our presentation. Please, Guy-Henri.
Thank you, Madeleine. I just want to underline two things. First, this week is National Canadian Recognition Week for the volunteering of people, and this is very important to us because we have many volunteers around us. And last 4 days ago, April the 17th is always World Hemophilia Day, and my sickness. And that's they highlighted the maze of the Olympic Stadium was turned into red because of that, and I believe that the CN Tower in Toronto was also with red lightning. So I just want to acknowledge that. So the first our first slide, we had meetings last September. And then November also 2020, and the very last one was the 12th of March. You can see on the right the list of the 26 different participants. And we're planning a next meeting virtually in next June, and we're organizing also a conference about excuse me, probably in September or next October, a conference about HIV and aging symposium. We brainstorm in the first two reunions, and these are the topics that we came out: the gender and longevity gap, the comorbidities, HIV co-infection like me, so because of tainted blood, HIV, and hepatitis C, and sometimes more than one hepatitis C genotype, the frailty, the inflammation, the permanent inflammation caused by those two viruses, the hormonal dysregulation for women, chronic pain, like hemophiliac like me who had hemarthrosis or bleeding in the joints by thousands. I don't say 100, I say thousands. Cumulative drug toxicities, polypharmacy, cognition, mental health, trauma, geriatric approach, holistic approach, the physical therapy. Some people suggest dancing. For me, it's a bit harder because I'm in a wheelchair. You don't see me right now. You just see the highest part of me, but I'm in a wheelchair. The wellness in general, the cultural approaches to aging, social determinants of disease, housing, nutrition, capacity building, communities of practice, and what any other intervention that works. So we're always open to suggestions or by other people. And we put up together an organizing committee with for the symposium about HIV and aging. It's will be put together by our friend Ellie Janabian and Cecilia Costignac, Elizabeth King, my friend from CAC, Carrie Martin, and Dr. Madeleine Durand also. And we came up with certain the metadata project, which is putting all together the informations that we gather, the showcase to showcase the huge potential of the CTN support cohorts by putting together all the data structure at each cohort. Okay, I received a message by Mina. She says there are some important points in the chat about the Black people. Racism and training. So I don't know if you want to say something.
So
Mina?
sorry, that was just to address the further comments. Sorry to interrupt, Guy-Henri. Go ahead.
Okay, we'll be back with that maybe after the presentation.
Perfect. Sorry about that.
Good. And we also aim to promote collaboration between the cohorts with the symposium that we will be putting together. And there's also an important research project about cannabisoid and inflammation pilot project, which is championed by Ali Janabian and Cecilia Costignac. The secondary analysis of the Canadian HIV and aging cohort study, and also the measurement of endocannabinoids in collaboration with markers and inflammation. That was all submitted last March 11 when we had our meeting. And we have another pain working group championed by Colin Price. The first meeting was held on last February the 12th. It's about local and international experts, trainees, community members, and researchers. And the BCC3 cohort to formally assess chronic pain and perspective survey. We invited as a guest an invited speaker, Dr. Manon Choinière. She's a doctor of psychology. I believe that her thesis was chronic pain amongst hemophiliac. And I remember meeting her for the very first time when I was about 19 years old, just about to enter University of Sherbrooke, the law school, and answering her questions and giving her my input. So it's a long time ago, more than 35 or 36 years. I'm just surprised to be still around. And I remember that very clearly. And Dr. Choinière is a senior researcher at the CHUM, a professor at the Department of Anesthesiology and Pain Medicine at the University of Montreal, but also a member of the Canadian Pain Task Force. And Madeleine Durand told me that her office is right next to Dr. Choinière's one. It's been for a long time. And Dr. Choinière has been a tremendous mentor for Madeleine, and she helped her a lot. So it is my pleasure to invite Dr. Choinière to share her talks and her experience with us.
Thank you, Guy-Henri, for taking us through all these slides. That was wonderful. So basically, the HIV and Aging RDT has promoted many projects already, and as Guy-Henri mentioned it beautifully, it's still a very open group. Everybody is welcome to join, and we will be in touch for the organization of the fall 3rd HIV and Aging Symposium. So everybody, this is an open committee, and please come and participate to our activities with much pleasure. The pain working groups have been put together through tremendous energy from Colleen Price, so we want to thank her at this stage. And we're thrilled to have Manon. Both Guy and Henri and I have known Manon for years. And personally, this is Manon, portrayed here as the fairy godmother of my last born. She has welcomed her into the world her very first day. Manon has been a tremendous mentor for me. As you see, she is still teaching me how to use Zoom properly. So it is with a great honor that we welcome her to give us a talk on living with chronic pain and HIV. Manon had no conflicts of interest relevant to this talk. And without further ado, I will stop my screen sharing and allow Manon, please, to start hers.
Thank you very much for this very nice introduction, Madeleine and Guy-Henri. I remember very well when you participated in my study many years ago, and I thank you once again. And I also want to thank Mona and Jason for having invited me to give this presentation. In fact, I'm really honored to give this, that the CTN asked me to give this talk. So I will share my screen. Excuse me, I made a mistake. It's not what I want to do. Share my screen. This. And you're sharing your screen. Now I want to have that full screen. And I have, excuse me. What is going on? Bon, okay. Now I have, you see, do you see 2 slides or only 1?
2 slides. So, yeah.
2 slides.
So do the.
Okay. I have to do what I was saying to, I was telling, but the problem is I don't see.
It's at the top in the middle.
Yes, I know, but it's, I have the
Madeleine clicked paramètres d'affichage.
yes, I know, but it's
the tricky thing with Zoom is that you don't always see all of your screen and you need to guess where the thing is. Je pense que c'est ce qui est en train de t'arriver maintenant. Mais va un peu à gauche.
OK.
À côté, c'est celui au milieu. Ça dit paramètres d'affichage. Oui, celui-là. Et puis,
it's okay. It's okay now?
Oui, c'est bon.
Okay, thank you very much. So, like I was mentioning, Madeleine was mentioning, I have no conflict of interest to declare. And my presentation about chronic pain chronic HIV-related pain. After having provided some definition, I will present some data on the epidemiology and characteristic of this type of pain. Then I will briefly cover the associated pain mechanism. And then I will discuss the impact of HIV-related on various aspects of daily living. And we will also discuss who are the persons who are the most likely to develop this type of problem. Then I will go over the different type of treatment for chronic HIV-related pain, with a special attention to pharmacotherapy and the opioid crisis. Then I will discuss some research avenue to improve pain management. We define chronic pain as a pain that persists more than 3 months. And the World Health Organization recently acknowledged that chronic pain is a disease in its own right. And you will see that in the 11th version of the International Disease Classification, there have been an important revision of the diagnosis for chronic pain. In spite of decades of research in the field of chronic pain, it continues to be poorly diagnosed, undertreated, mistreated, or not treated at all. Why pain continues to be poorly managed and underfunded funded in 2021, but it's not very complicated. It's because it's not a sexy topic. Chronic pain, people don't die for chronic pain, or rarely. It's also a subjective experience with no objective measure. And chronic pain always raises doubt, suspicion, and it's very stigmatized. People who live with chronic pain are lazy people, they don't want to work, it's all in their head, and so on and so on. And there are several barriers to adequate management of chronic pain. The most important one is the poor training of the clinician and the healthcare professional. But the nice thing, we will see the next few years some improvement in their training. The other aspect is that chronic pain is a very complex phenomenon with multiple dimensions. And what happened is that clinicians very often use the biomedical model of disease, which focuses on pathophysiology rather than overall quality of life. And there are a lack of specialized pain treatment resources. Half of the multidisciplinary pain clinic across Canada, pain treatment clinic, have a waiting list which is greater than 6 months. And it even goes to 4 years, and that they are mostly located in large urban centers. So there is really a lack of access to this type of treatment. Now about the chronic HIV-related pain, the prevalence estimate range from 25 to 85%, but there is a consensus that it is greater than in the general population. It's more prevalent and more severe in women who live with HIV than in men, and the prevalence and the severity increase significantly with age. What types of chronic pain people living with HIV have? First, it can be a neuropathic pain, which is due to direct damage to the peripheral or central nervous system due to HIV infection, its treatment, or other causes like painful diabetic neuropathy, neuropathy resulting from alcohol use disorder. It can be also not a direct damage to the neurons, but a change in the way they function. They become more responsive, more sensitized. And with respect to peripheral neuropathy, it's usually described as burning or shooting pain. And allodynia and hyperalgesia are commonly experienced. The second type of pain, which is probably more frequent than neuropathic pain, is due to damage to body tissue like musculoskeletal pain associated with osteoarthritis or primary low back pain of unknown origin. And also people living with, excuse me, and a large number of people who live with who live with HIV commonly experience pain in more than one side, and close to 20% who have pain have widespread pain. In terms of the mechanism associated with chronic HIV-related pain, current research suggests that persistent immune activation may be involved in the development and maintenance of chronic pain in people living with HIV. Other studies also suggest that chronic inflammation in people living with HIV may contribute to neuronal sensitization and chronic pain development. Like I was mentioning before, pain is a complex phenomenon. It's much more than a simple electrical impulse generated in the skin that is transmitted to the brain. And the biopsychosocial model of pain proposed by Gatchell emphasizes the multidimensional nature of chronic pain, which include not only the structural pathophysiology of nociception, but also the dynamic interplay of the individual thoughts, emotion, behavior, and cultural influences. Well, the people who experience people living with HIV who have chronic pain will have the pain will have many impact on various aspects of their daily functioning. For example, it will decrease their physical functioning. They will have an impact on their work productivity. And many people who live with chronic pain, including people with HIV, will complain of poor sleep quality. Another aspect which is common is that many people with chronic pain, including those with HIV, have mental problems, including depression and suicidal ideation. The pain has also an impact on the family and the social activity and the overall health-related quality of life. The healthcare use is also greater in people living with chronic pain, and it has been shown that people living with HIV who have chronic pain are less adherent to their therapy, and the care retention is also decreased. In terms of the predictors of chronic pain in people living with HIV, like I was mentioning before, older age and being a woman are predictors, but a frail phenotype is also a predictor. People with higher body mass index are more likely to develop chronic pain, and people with HIV and lower level of education who are unemployed and who have a financial instability are also more likely to develop chronic pain. Those with anxiety disorder, post-traumatic stress disorder, or a former or current substance use disorder are also more likely to develop chronic pain. What about the management of chronic HIV-related pain? In 2017, the HIV Medicine Association, along with the Infectious Disease Society of America, have issued practice guidelines for the management of chronic pain in people living with HIV. I do not have time to go over all the recommendations, and I will limit myself to those that I consider the most important ones. The primary recommendation is the use of a multidisciplinary approach for the treatment of pain, in which analgesics are combined with physical, behavioral, and psychological therapy, along with self-management technique. The goal is not to eliminate the pain, but to achieve functional restoration. And like I was mentioning before, the lack of access to specialized pain management services as the patient has to rely on the HIV clinical providers, but this does not prevent that they partner with the healthcare professional from other disciplines for complex cases, and especially those who have mental health problem or substance use disorder. Another key recommendation in the guideline is pain assessment. And of course, the proper assessment of pain is the cornerstone to providing effective pain management. They recommend routine standardized screening for pain. And if the patient report pain in the past week and it lasted for more than 3 months, it's proposed to use a biopsychosocial approach to assess the patient pain experience and its impact of various aspects of daily living, including work, sleep quality, etc., etc. And of course, it is recommended to monitor periodically the effectiveness of treatment and the side effects. In terms of the results of the systematic review on pharmacological treatment for HIV-related pain revealed only low or very low quality studies, and the author concluded that at present, pharmacological modalities, including opioid medication, appear to have limited efficacy for managing chronic pain in many individuals living with HIV. With regards to psychological approach, such as cognitive behavior therapy or psychotherapy, they can be helpful for managing chronic HIV-related pain. Oops, sorry. They can be helpful, but again, the quality of evidence is poor in many studies. Physical therapy and self-management intervention, whether they are online, face-to-face, or group-based, appear promising for managing not only pain, but other physical symptoms in pain living with, in people living with HIV. With regards to pharmacological treatment, it will depend, the medication to be prescribed will depend whether the patient has neuropathic pain or nociceptive pain. If it's a neuropathic type of pain, gabapentin will be the first line treatment. Antidepressant, capsaicin can be used, and opioids are recommended only as second line or third line treatment, considering the limited efficacy on the long term, but about 20% of people suffering from chronic pain can benefit from opioids. With respect to cannabis use for pain treatment, to my knowledge, there are only 2 studies in the field of HIV, and the results are contradictory. Also the study are not of very good quality. If the pain is a nociceptive type of pain, acetaminophen and NSAID can be helpful, especially if there is an important inflammatory component. And like for the neuropathic pain, opioids are only second line and third line treatments. I want to take a few minutes here to stress the fact that the opioid crisis and the death due to overdose, along with the publication of American and Canadian guidelines for opioid prescription, had and continue to have negative effect on people who live with chronic pain. Many of them who were functioning very well with their opioids had their medication stopped or reduced, leading to useless suffering, increased anxiety, and in some cases to the use of illicit drugs. Also, some physicians, since the opioid crisis, which, and we must say that it's even worse with the COVID-19 pandemic, some physicians refuse to treat people with chronic pain. and those who continue to take opioids are perceived as drug addicts, and this is more and more with the media coverage of the opioid crisis. So if if you suffer from chronic pain, you have that, and using opioid use and using opioids to relieve your pain, you are stigmatized. Like I was mentioning before, if you have chronic pain, you have a second stigma. And the top of that, if you have HIV, you are even more stigmatized. So it is this combination of stigma is commonly associated with more severe depression symptoms. And also the stigma due to HIV, chronic pain, and opioid use may interact to compromise health-promoting behaviors such as medication adherence and good patient-provider relationship. There are, of course, risk associated with long-term administration of opioids, including hyperalgesia, cognitive impairment, endocrine and immunological changes, respiratory depression, and misuse, opioid use disorder, or addiction, the term that you prefer. But a trial of opioid treatment for moderate to severe pain may be quite reasonable when the potential benefit in terms of pain severity, physical function, and quality of life outweigh the potential harms of opioids. And here, and for the people, so what is recommended in the ISDA guideline is that it's reasonable to have an opioid trial for moderate to severe pain, and when the pain is moderate to severe and there is functional impairment that is not responsive to first-line or second-line analgesics. The idea is always to balance the benefit versus the harms of the opioid. It's also recommended to combine long-acting and short-acting opioid plus other modalities, physical, psychological, and self-management strategy. It's also, it can be combined with gabapentin if it's a neuropathic type of pain. There are several recommendations in terms of being careful and closely monitor the patient who are on opioid treatment to educate them about safe storage, use of naloxone, and so on and so on. In people with a history of a substance use disorder, the ISDA guideline recommend the same strategy as all in other people living with HIV. It's the use of the opioid medication must be assessed in a benefit risk framework, and if needed, you can consult with an addiction specialist to use precaution approach, of course. But we also must remember that pain management is a fundamental human right, and this was in the Declaration of Montreal in 2010. And in fact, it's that every person deserves to have her pain or his pain reasonably managed by adequately trained clinicians, and that every provider has the duty to listen and reasonably respond to patients' pain report. However, the Canadian guidelines for the opioid prescription do not recommend the use of opioid in people with current or past substance use disorder. But we have to realize that the prevalence of chronic pain in people with substance use disorder is around 40%. And if their pain is not adequately managed, what they will do, they will use illicit drugs, including illicit fentanyl, thereby increasing their risk of overdose. And another, an interesting model to the lack of access, to a solution to the lack of access to specialized pain treatment is the hub and spoke model. And the University Health Network in Ontario has such a model for chronic pain and opioid stewardship. And what this type of model, it allows to connect primary care providers with pain specialists of different disciplines. And these, the primary care providers present via teleconference patient cases, and the hub members make recommendations. There is also some light at the end of the tunnel with the Canadian task force, which was established by Health Canada toward an improved approach to the prevention and management of chronic pain in Canada. And their mandate has been recently accelerated and reinforces, and they have mandated to publish by the end of April an action plan consisting of a set of recommendations across 6 goals to improve the access to pain care, to increase specialized training of pain, to support pain research, and to ensure equitable approaches to population disproportionately impacted by pain. Another light at the end of the tunnel is the recent creation of the Global Task Force for Chronic Pain in People with HIV. It is an international task force, and it's provide an important platform for future research collaboration and potential to shape the future of global research in HIV pain. Where do we need to focus our research attention over the next years to improve the model and the process of care for chronic HIV-related pain? The task force, the member conducted a study among HIV experts to identify knowledge gaps in the field of HIV and chronic pain. And they have also prioritized research and clinical area. For example, they recommend one of the recommendation is the need to get more studies to characterize etiology and mechanism of chronic pain, and also how chronic pain, HIV-related pain, best be managed, including non-opioid and non-pharmacological modality. but they also insist a lot on the importance to standardize the pain-related measurement domains in future clinical trial and also across around the world. But I would go even further than that, because I think that if one wants to improve the management of chronic pain in HIV, in people living with HIV, it's absolutely, excuse me, essential to integrate standardized evaluation of patient outcome and quality of care in clinical setting by using, for example, uniform minimal data set, which constitute the core of a patient pain registry, which serves both clinical and research purposes. Excuse me. And why do we have to do them? Because what gets measured gets improved. And it's so important, and we don't have this culture in our healthcare system. Another aspect which is important to consider is that the patient-centered care is viewed as a central component of high quality of care by the Institute of Medicine. And what does it mean? It ensures that the right patient receives the right treatment at the right time by the right healthcare provider. But there is some sort of paradox. On the one hand, we promote patient-centered care and personalized medicine, but on the other hand, we base our care on data obtained from randomized controlled trials. And the result that we have in these RCT are data which are average over groups or time points. But who is the average patient? Does he or she exist? And even with the number needed to treat, it doesn't tell us who is the right patient for the right treatment. So I think that we have to seek our answers elsewhere and otherwise in the field of pain, some sort of paradigm shift. And we need more research on the real-life condition of clinical practices. For example, studies that we can do with registry of patients followed over time. We also need to use more sophisticated analytic method focusing on inter-individual pain variability. Here you have the mean result, the average score, intensity score over time of a group of patients who were treated in pain, in multidisciplinary pain clinic. And if we look at these average results, it's not very impressive, and it's even not clinically significant. But if we use more sophisticated statistical analysis, we are able to identify subgroup of patients with similar trajectory, like the non-improver, the steady improver, and the early improvers. And the interesting thing is that after that, we can look at which factor will predict membership to one trajectory or another. So, in my opinion, if we integrate the evaluation of patient outcome and quality of care into clinical setting, and it's served also for research purposes, plus observational study in a real life context, and with more focus on inter-individual pain variation, I think that we will get evidence-based data for patient-centered care to improve the condition of people living with HIV chronic pain. I want to thank the organization and who fund my my research and the organization to which I belong. And I'm sorry I took 5 minutes more than I was allowed to. It's because I'm too passionate when I talk about chronic pain. So I will stop sharing my screen, and I will be more than pleased to answer your question.
Thank you, Manon. Your passion is certainly contagious and justified by the importance of this topic. Thank you for this wonderful talk, so comprehensive, touching on so much there and giving us so much work to look forward to. So I'll ask everybody to write their questions in the chat, please. We already have one for Neora, and Colleen and I will be animating the Q&A for the time that we have left. May I start by asking you, Manon, thank you for identifying so many of the specific components that make living with chronic pain and HIV different from living with chronic pain. And I know you are having a key role at the Canadian Pain Task Force, and thank you for moving this agenda forward. How do you think the community of people living with HIV can leverage the Canadian Pain Task Force and advocate for people living with chronic pain and HIV to the
like I was mentioning in my presentation, the Canadian Pain Task Force were very, very keen to take the equity lens, because many people who live with chronic pain also live in poverty, indigenous people, Black people, and it's going to be very important in the recommendation of and I think that people living with HIV should be one of this target population, and they will submit the report. We will, because I'm part, we will submit our report at the end of April, and I'm working in this field for more than 30 years, and it's the first time that I see that the government, the federal government, want to really have a strategy. And in the next few months, we will work with the federal, the provincial, the territories agency to implement these recommendations.
Thank you. May I read one question from Neora that she posted in the chat, and then I will hand over the mic to you, Colleen. So Neora was asking, what is the mechanism of pain in former substance abuse users? They are often talked about separately. So do they have a special mechanism of pain?
But usually these people will need higher dose of opioid because they have developed some tolerance to the medication. So this is one thing that we know. But like I was mentioning, it's so important that it's a combination of treatment. It's a combination of different medication and of different pain treatment modalities. It's really the key to for optimal management in people, whether they have substance use disorder or not. But to me, it's important that people with it's part of the group of people who have their pain neglected, and the treatment is not equitable. And so And these people deserve, like I was mentioning, pain relief is a fundamental human right. And it's not because you have a substance use disorder that you should be denied pain treatment.
Colleen, would you like to ask the next question? And then we have a couple very interesting questions in the chat as well.
I just wanted to say thank you for the wonderful, wonderful presentation. I've been living with chronic pain and HIV for over 30 years. What really strikes me is, you know, there's so much stigma and discrimination. And there's really a shortage of people trained, you know, clinicians, doctors, physicians. There's nothing in frontline, there's no services. You know, it is a gaping hole. So, you know, I'm wondering, what are the answers? You know, how can community truly be involved with the task force? You know, it's not enough to have just the doctors or just the
No, but the task force, we have in the task force and our external advisory committee, there are people who are living with chronic pain. It is absolutely essential that we have the people with chronic pain on board. Otherwise, it's going to be a failure. But I really think, and you know, people who are living with chronic pain, they are voters and they can influence the government. I remember many years ago, I went to meet with a senator at the government to have a national pain week. And we were two researchers, and we came to his office and we explained what we wanted to have. And he told us, the first thing he asked us is, where are the patients? So, and people do not realize that they can put pressure, and we hope very much that with the Canadian Pain Task Force, there will be really a significant change at the federal, provincial, and in the territory level that will improve the condition of people who live with chronic pain, including those with who also live with HIV.
I just wanted to ask also briefly, you know, how would we go about training physicians, clinicians to deal with us? The stigma truly is overwhelming, and I like your slides about the multiple stigmas. You know, I had the HIV, I had being a woman, also being formerly co-infected and a substance user. Being a substance user was probably the ultimate in the stigma and discrimination. I was just wondering if you had suggestions that might help.
I think that like I was mentioning before, that we were very concerned during all the work of the Canadian Pain Task Force about this equity question, notion. And when the report will be published, you will see that there are specific recommendations about that. And I personally think that it will change things.
Thank you.
Manon, I think we might have time for a last question, and we have 3 wonderful questions in the chat that revolve around non-pharmacological therapies. And there's 2 aspects there. One aspect is about what is the evidence that is available for non-pharmacological therapies and pain management. And of course, they are various. There's CBT, there's meditation, mindfulness, exercise, non-traditional medicines. And the other question is, what is the situation on access? We know that often these parts of healthcare are not insured in Canada. So your thoughts and experience on these issues.
You know, these other non-pharmacological modalities are so important for an optimal management of pain. And there are evidence in the field of chronic pain in general that these modalities can be extremely helpful in combination with medication. For example, if a patient is not able to exercise because of pain, and you give him some medication which allows him to exercise, but his functioning will obviously improve. So, and it's often more than one exercise combined with CBT or mindfulness, and also self-management strategy are extremely important, because very often people who live with chronic pain have very poor sleep hygiene, and there are basic principles that they can learn and benefit, and also with relaxation technique and simple relaxation technique, and so on and so on. So it's extremely important. I forgot your second question, which was?
A word on access to all of these non-pharmacological therapies.
That's the big problem. And this is one of the recommendations that will be addressed in the report of the Canadian Pain Task Force. Because in Canada right now, if you want to have access to a physiotherapist or a psychologist, you have to pay for that. And many people who do not have private insurance cannot have access to this type of treatment. However, there are peer support groups which are available, and self-management strategy. For example, in Quebec, the Quebec Association of Chronic Pain Patients offer a support group across the province. In Pain BC, they are doing a wonderful work with the organization Pain BC, and it's really a golden mine for the people who live with chronic pain in terms of resources for self-management strategies.
Thank you, Manon.